Good morning, everyone. Welcome to the Orlando GI Journal Club. This is July 2nd, 2025. Our first study is by Vander Shea et al., published in Gut. This is looking at endoscopic intermuscular dissection for deep submucosal invasive rectal cancer. This is a 3-year follow-up study. Endoscopic intermuscular dissection is a new technique for managing patients with deep rectal submucosal invasive cancer, shortened to DSMIC. And that's when the submucosal invasion is up to SM2 or SM3 in depth. So this technique is a little bit deeper than ESD, which is an endoscopic submucosal dissection. In endoscopic intermuscular dissection, the dissection occurs within the intermuscular plane of the muscular propria to achieve tumor-free deep resection margins. Deep submucosal invasion is considered an independent risk factor for lymph node metastases and/or recurrence, with total mesorectal excision recommended in surgically fit patients. But recent data suggests that the risk of lymph node metastases in patients with submucosal invasive cancer is lower than originally thought at 2.6 to 5%. And when additional histological risk factors are, especially when additional histological factors are absent. So this then raises the question as to whether these cancers can be managed locally and whether total mesorectal excision is necessary for all of these patients, especially as 40% of these cases lack other histological risk factors for lymph node metastases. So the aim of this study was to assess a 3-year oncological outcomes of endoscopic intermuscular dissection in a prospective cohort of patients with suspected rectal deep submucosally invasive cancer. This is a prospective study from 2 institutions. They enrolled 188 patients who underwent EID for deep submucosal invasive cancer and then underwent 3 years of active surveillance. They, in addition to R0 resection or assessing resection margins, they also looked at other histological risk factors, which includes being poorly differentiated, lymphovascular invasion, high-grade tumor budding, and then obviously positive or indeterminate resection margin. The outcome measure was the incidence of local regional recurrence, both intramural and nodal, distant recurrences, metastatic disease essentially, recurrence that was non-salvageable, cancer-specific mortality, and need for secondary rectal surgery. So this is 188 patients were enrolled in this study. The mean age was 66 years. The majority of patients were ASA class 1 or 2, 85% in fact. The median diameter of the lesion was 25 millimeters, actually fairly small. The majority of the cancers were within 5 centimeters from the anal verge, 57%. Depression was present in 90%. In terms of Kudo pit pattern, it was classified as type 5, basically in the majority of cases, about 97%. And when these patients had an MRI, it was determined to be T1 to T2 cancer in 64% of cases. Out of 188 patients, technical success was achieved in 177 patients. That's 94%, where the cancer was able to be resected. When looking at the histology, 29 of these 177 patients had either non-invasive or superficial submucosal invasive cancer, and 59 patients had T2 or more advanced cancer, and 98 patients had our cohort of interest, which is deep submucosal invasive cancer. That's 98 patients. Now, when looking at the overall rate of adverse events, it was 18.6%, and the majority were mild or non-severe, grades 1 to 2, according to the AGREE classification. But as you can see, the adverse event is greatest for patients who underwent resection for deep submucosal invasive cancer and T2 cancer. R0 resection was achieved in 82.5% of these 177 patients in whom the cancer was able to be resected, with R0 resection achieved in all 29 patients with non-invasive or superficial submucosal invasive cancer, 91.5% of patients with deep submucosal invasive cancer, and 57% in patients with T2 or more advanced cancer. Histological risk factors were absent in 36% of the 177 patients who underwent resection. Risk factor was present in 1 of 29 patients with non-invasive or superficial submucosal invasive cancer. That's 3.4%. And at least 1 risk factor was present in 63% of patients with deep submucosal invasive cancer, which consisted of lymphovascular invasion in 49%, high-grade tumor budding in 33%, and high-grade differentiation in 9.6%. In patients with T2 or more advanced cancer, additional histological risk factors were present in the majority of patients, 87% in fact, consisting of lymphovascular invasion in 63%, high-grade tumor budding in 54%, and high-grade differentiation in 15%. When the patients were followed to look at additional treatment strategy after completion of the endoscopic intermuscular dissection, the adjuvant treatment was undertaken in 39.5% of the total cohort, so that's 70 of the 177 patients. Chemotherapy was administered in 9% of these patients in total. There was total mesorectal excision was performed in 29.9%, and completion TAMIS was undertaken in 0.6% of these patients. Surveillance only was undertaken in 60.5% of these patients, and actually in patients with deep submucosal invasive cancer that were considered low risk, which basically meant that they had no additional histological risk factors. Surveillance was completely undertaken. So surveillance was undertaken in all 35 of these patients. For patients with considered intermediate risk for deep submucosal invasive cancer group, surveillance was undertaken in 72%. And surgery with total mesorectal excision was performed in 22%. In patients who were considered high risk for deep submucosal invasive cancer, surveillance was undertaken in 22%. And in these patients, total mesorectal excision was undertaken in 56%, and chemotherapy was administered in 22%. This is a result of the 3-year oncological outcome. This is reported in just the patients with deep submucosal invasive cancer, so not the patients with non-invasive or superficial submucosal invasive cancer, or really advanced cancer, T2+. So in the deep submucosal invasive cancer, local regional recurrence in patients who were low risk, in the low risk category for deep submucosal invasive cancer, was 7.1%. And there was no recurrence in this group, no distant recurrence, no non-salvageable recurrence, no cancer-specific mortality, and secondary surgery was performed in 5% of these patients. In patients who are considered intermediate risk for deep submucosal invasive cancer, which means that they had one additional histological risk factor other than the deep submucosal invasion, local regional recurrence rate was 9.2%, with distant recurrence rate of 3%, and secondary surgery was performed in 25%. Again, in this group, there was no non-salvageable recurrence and no cancer-specific mortality. Patients who are considered high-risk deep submucosal invasive cancer, which means that they had 2 or more additional histological risk factors other than deep submucosal invasion, local regional recurrence occurred in 8.2%, and secondary surgery was performed in 59.6%. But in this group, there was no distant recurrence, there was no non-salvageable recurrence, and 0 cancer-specific mortality. The limitation with this study is that the key subgroup of interest, which was rectal deep submucosal invasive cancer with either no or one additional histological risk factors, was relatively small. And here in the study, they defined R0 resection as tumor-free margin of at least 0.1 millimeter, whereas by the ASGE and International Collaboration on Cancer Reporting, they define that as tumor-free margin of at least 1 millimeter. The 3-year follow-up is shorter than the 5-year surveillance period, which they normally undergo, and therefore they may potentially be underestimating recurrence. However, they do report that recurrence is most likely to occur within the first 3 years, so they do not consider to be an important limitation. The take-home point is that despite the challenges associated with accurate preoperative staging, endoscopic intermuscular dissection followed by active surveillance may offer a viable alternative to radical surgery for patients with low and intermediate risk rectal deep submucosal invasive cancer, avoiding rectal surgery in most cases, while maintaining oncological safety. Our next study is by Sanyal et al. In the New England Journal of Medicine, looking at semaglutide in patients with metabolic dysfunction-associated steatohepatitis. Semaglutide is a glucagon-like peptide 1 receptor agonist approved for treatment of diabetes and has been proposed as a potential candidate for treatment of metabolic dysfunction-associated steatohepatitis. The aim of this study was to compare semaglutide with placebo in a biopsy-defined metabolic dysfunction-associated steatohepatitis and fibrosis stage 2 or 3. So these authors performed a phase 3 multicenter randomized trial. This was double-blind, placebo-controlled. A total of 1,197 patients with biopsy-defined MASH and fibrosis stage 2 or 3 have been enrolled. These authors are presenting in this publication the interim analysis on the first 800 patients. They were randomized in a 1-to-1 ratio to either semaglutide weekly at dose of 2.4 milligrams versus placebo. The primary outcome measures the resolution of steatohepatitis without worsening of liver fibrosis and reduction in liver fibrosis without worsening of steatohepatitis. So a total of 534 patients were randomized to semaglutide, 266 patients to placebo. The mean age is 56 in semaglutide, 55 in placebo. In terms of presence of coexisting type 2 diabetes, this was 55% in semaglutide, 56.8% in placebo. Fibrosis stage 3 was in 68% of semaglutide, 69% of placebo group. When looking at the primary endpoint, they found that the rate of resolution of steatohepatitis with no worsening of liver fibrosis was significantly higher in the semaglutide group at 63% versus 34% for placebo, with a risk difference of 28.7%, with a statistically significant p-value of less than 0.001. When looking at the reduction in liver fibrosis with no worsening of steatohepatitis, again, semaglutide was superior with this regard at 36.8% versus 22.4% for placebo, with a risk difference of 14.4% and p-value of less than 0.001. What I find really interesting is that they had an improvement in steatohepatitis and liver fibrosis with placebo. It is significantly lower than semaglutide for sure, but the fact that it's even positive is kind of interesting. Yeah. Okay. Next, when looking at change in cardiometabolic features, they found that there was a significantly higher reduction in blood pressure, both systolic and diastolic, with semaglutide compared to placebo at week 72. There was a significant higher reduction in the HbA1c with semaglutide compared to placebo. Also, when looking at the levels of high sensitivity CRP, the difference was significantly higher with semaglutide than placebo. And again, with triglycerides and total cholesterol, although when looking at the individual levels of LDL and HDL, the 95% of the difference encompasses 0, so it doesn't seem to be statistically significant. For LDL, I beg your pardon, for HDL, it is higher. The increase is higher with semaglutide. Adverse events, the serious adverse event rate was 13.4% in semaglutide versus 13.4% in placebo. And when looking at limitations, they needed to be more racially diverse with their patient recruitment. Changes in body composition during therapy was not recorded. And given small number of lean patients, they say that definitive conclusions of benefit in this population cannot be made. The take-home point is that in patients with MASH and moderate or advanced liver fibrosis, once weekly semaglutide at dose of 2.4 milligrams improved liver histological results. Our final randomized trial is by Jewell et al. In the Annals of Internal Medicine. This is looking at FMT versus vancomycin as the primary treatment for C. diff infection. FMT, as everyone is aware, is recommended for recurrent C. diff infection, but its role as treatment in primary C. diff infection is unclear. So these authors wanted to investigate the efficacy and safety of FMT in the treatment of primary C. diff infection. This was a multi-center, non-inferiority open-label randomized trial with non-inferiority margins set at 25%, conducted in Norway in 20 centers. These authors enrolled 100 patients with a primary C. diff infection defined as diarrhea of at least 3 loose stools per day, positive stool test results, and no previous C. diff infection within a year prior to enrollment. They were randomized in a 1-to-1 ratio to FMT without pre-treatment with any antibiotics and oral vancomycin for 10 days. And for FMT, they used the Norwegian Stool Donor Bank. The primary outcome measure was clinical cure, defined as firm stools or less than 3 bowel movements a day at day 14 with no disease recurrence within 60 days with the assigned treatment alone. 51 patients underwent FMT, 49 patients received vancomycin. The median age was 70 in FMT, 71 years in vancomycin. The source of infection was community-acquired in 71% of the FMT group, 55% of the vancomycin group. Antibiotic use was documented in 90% of FMT and 86% of the vancomycin group. When looking at clinical findings, abdominal tenderness was present in 57% of FMT, 45% of vancomycin, 2% in the FMT group had a fever, and the C. diff infection was considered severe in 33% of FMT and 35% of vancomycin group. When looking at the primary endpoint of clinical cure at day 14, without recurrence within 60 days of treatment. In the FMT group, this was achieved in 66.7% of patients. In vancomycin group, this was achieved in 61.2% of patients with a risk difference of 5.4, which was considered significant when looking at p-value for non-inferiority. When looking at the secondary endpoints of clinical cure at day 14. This was achieved in 84% in FMT versus 79.6% in the vancomycin group. And for recurrence at days 15 to 60 days, this was seen in 7% in FMP, 23% in the vancomycin group. In terms of adverse events, there were no adverse events, any adverse events occurred in 45% in FMT, 35% in vancomycin group. The adverse events were considered serious adverse events in 25% in FMT, 16% in vancomycin. The limitation of this randomized trial is the reliance on clinical endpoints without stool tests for C. diff infection or FMT engraftment after treatment. This was an open label design due to the differences in the treatment modality, and so there's a risk of bias there. And in this study, FMT was not compared to fidaxomicin, just vancomycin. So the take-home point is that FMT may be considered as first-line therapy in primary C. diff infection. So to recap, despite the challenges associated with the accurate preoperative staging, endoscopic intermuscular dissection followed by active surveillance may offer a viable alternative to radical surgery for patients with low and intermediate risk rectal deep submucosal invasive cancer, leading to avoidance of rectal surgery in most cases while maintaining oncological safety. In patients with MASH and moderate or advanced liver fibrosis, once weekly semaglutide at dose of 2.4 milligrams improved liver histological results. FMT may be considered as first-line therapy in primary C. diff infection. Just to highlight, it's now time nearly for Florida Live EUS 2025. This will be taking place August 21 to 23. Please register and join us. Our next journal club will be on August 6th, 2025. That's the first Wednesday of August. Thank you so much. Have a good day, everyone. Bye.